Log on, tune in, find out. Another good idea from Cambridge.
For joining us here for an exciting afternoon session. This morning we kind of heard the big overview talks promising all the fancy, sexy things. And this afternoon we'll deliver. Also, please, this is a very nice room, like we are almost right up to the speaker. Please interrupt anytime, ask, comment, yeah? Like some of the speakers say outrageous things. I mean, comment, react to it.
Sorry, we have 2 stars and we only get 1. 2 courses.
Costs £38 a second star. So please feel free to chip in anytime. I would really appreciate it. Yeah? And we'll still finish on time for the coffee. So this session, is about different smart ways of doing treatment individualization. And I hope we'll actually hear some of the actual details of how to implement it. And our first speaker is, come in please. Our first speaker is Jack Lee from MD Anderson Cancer Center in Houston. Please check.
Thank you.
So please chip in any moment, yeah?
Well, Peter said that this room is like a Coliseum setting. So after the talk, he will send a lion in.
Only for the speakers.
Only for the speakers. Yeah, that's right. Okay. Thank you for the invitation, and I'm very glad to be here participating in this week-long interesting workshop. And as you heard from Don in the morning about many adaptive design and particular I-SPY 2, you will hear more from Kyle. But in my session, I'd like to show you what we have learned in this so-called battle trial, and it's a biomarker-based Bayesian adaptive design for targeted agent development. I will focus more on the implementation and the lessons learned, and also tell you a little bit more about outcome-based adaptive randomization. And this is a joint work with Suyu and Nan. Okay, so to set the stage, the premise that we have right now in the drug development is that there are many new target agents and many more potential combination therapies to be developed. Okay? Unfortunately, the success rate for oncology development is very low, as you have seen earlier. Targeted agents do not work for all patients, we know that, and actually they may not work at all. And the big question is that, are there markers to guide the choice of treatments? We also want to treat patients best in the trial, and then we also like to know how to gauge the treatment effect, if there's any, whether we should use the response rate, disease stabilization, or improved survival. And in clinical trial, even though there are lots of cancer patients, but actually maybe overall it's about only 5% of the patients enrolled in clinical trial. So there's limited patient population, and time is of an essence. So basically, the challenge we are facing now is that, Moses is here. How to best identify markers, gauge treatment efficacy, and treat patients in a clinical trial. So those are the 3 questions, please keep in mind. Okay, so that's the main focus that we try to solve the problem. So the traditional drug development is like this way. Okay, we start with small phase 1 studies, a few single-arm trials. Then we do a few single-arm, a little bit larger phase 2 trials. Maybe we'll move to randomized phase 2 trial, okay? And then after that, we design this huge, randomized phase 3 trial. And if you put this in the diagram, actually I learned this, I first saw this from Don, but I kind of remake the slide, okay? So the phase 1 trial typically involve less than 50 patients. And phase 2 is about 50 to 100 patients. And phase 3, you have hundreds and thousands of patients, right? And in phase 1, you investigate the multiple doses and schedules. For phase 2, we expanded to we limited to a few doses and schedules. There are still seats here. Please come over. Yeah. Okay, and in phase 3, we have one dose and one schedule. And as you can imagine, if you put this invert pyramid on on the ground or on a desk, what will happen? It's going to tip over, right? So no wonder, our success rate is so low. Okay. So, and we need to do different things in drug development, but recently, or maybe in the last 2 decades, sort of biomarkers come to rescue. Right? And I use an example of non-small cell lung cancer. So traditionally, okay, this is the view of non-small cell lung cancer. Okay, so based on histology, I don't know if you can read, but we have we can classify the non-small cell lung cancer into adenocarcinoma, squamous carcinoma, and large cell. Okay, and in 1987, we only know one marker called KRAS mutation, okay? And all the rest is unknown. And in 2004, we know, the 2 groups in Boston identified the EGFR mutations. And just in a short 5 years, you see many, many more mutations being identified. Okay? And on the right here, you see the distributions of the different type of mutation. And you know what? For each type of mutation, they tend to have a very effective drugs. Okay? So for patients with EGFR mutation, even though they are only about 5 to 15% of patients have that, but if you treat them with this thing called alartinib or gefitinib, these are the TKI, tyrosine kinase inhibitor, they are very effective. And for ALK fusion, and now there's a drug called quizartinib. And for HER2, as we learned from breast cancer, we have trastuzumab. Okay, so if you can identify different type of mutation, then there's a better chance that we can treat the patient more successfully. But this kind of information, you don't know it when you start, right? So if you have tier 1 evidence, okay, means that it's very strong. Okay, you already know there are lots of trial, study being done showing that. Maybe what you should do is just assign patient to treatment, and you can use single arm study to confirm the result. If you have a tier 2 evidence, maybe you should randomize, right? And if you have tier 3 evidence, or you just start, to learn about it, maybe you should do a single arm screening trial with futility, early stopping, or do randomized screening trial. Yes?
Just a quick clarification. Are these different subtypes, they are non-overlapping as indicated by the charts, or there's actually an overlap?
Yes, very good question. Very little overlap. There are some overlap, especially for KRAS and the EGFR. Initially, people say there's completely non-overlap. But as we do more cases, indeed there are overlapping patients. And if patient with, one other thing makes cancer hard to treat is that cancer cells tend to divide all the time, right? And then they also have mutation. And especially if you give them one drug and you kill 99% of the cancer cell, you know what? The remaining 1% are drug resistance, and they may have developed mutation to kind of bypass that pathway. So it's very hard to treat. So for patients with multiple mutation, maybe one ought to use combination drug to treat them.
And Jack, you show these 9 as though there are 9. There are probably 9,000, 9 billion.
Right.
With lots of overlap. And,
yeah.
And I mean, even if we were to understand these perfectly and treat them wonderfully, cancer mortality is not going to be changed all that much.
Correct. It's very, very, very good point. And actually, in Vanderbilt, for example, and in Moffitt, and recently also started MD Anderson, our goal is that for every new patient comes in, we like to do this kind of mutation analysis, okay? And we like to characterize the patient and then know how to treat. Yes, there's another question?
That
Somebody?
was my question.
Oh, okay, okay.
So you know the characteristic of the cell
Yeah.
as soon as you actually can take biopsy or something?
Right. Okay, very good point. Okay, you will see in a minute that one of the really actually, maybe let me just tell you what's the result of the Vettel trial. The end result, the efficacy point of view is not that exciting, but we have changed the paradigm of conducting cancer trials in refractory patients. Means that these patients are subject to several lines of therapy and then recur. The cancer comes back. Okay, so most people, most places, the standard way is just try some other thing. They will not take biopsy. Okay? But we convince people that we can do this kind of trial. You take biopsy at the time when patient comes in, even though if they recur, okay, and analyze the marker profile, and then treat the patient accordingly. So that can be done. Okay, so there's a recent publication, Cancer Science 2011, and I use this as an example. It's basically a randomized phase 2 trial for testing the 5-gene signature of paclitaxel sensitivity in breast cancer. Oh, okay, thank you, Peter. So the design is like this, okay? You register patient, randomize them into 1:4 ratio, okay? So the group A, that you don't use this genetic sensitivity testing, okay? And group B, then you use this 5-gene signature. So if they are sensitive to paclitaxel, okay, you basically use, actually this part is a 4-to-1 randomization. You treat more patients with paclitaxel, and then if not sensitive, then you treat with standard therapy, okay? And then after that, then you do surgery, okay? So before the trial start, the prior data, actually based on the previous publication on this 5-gene signature, says that if you use the standard therapy, okay, the estimate pathology response rate is 30%. But if the patient is sensitive to paclitaxel, it's 80%. And they did a trial. Lo and behold, this is the result. Okay, so actual path response rate is 21% if you give standard therapy. It's only 36% if you give, using this gene signature. So what's the lesson learned? The lesson is that we think we know many times, but oftentimes we really don't. Okay? We need clinical trial to confirm or refute the hypothesis. Okay? So the key word, as you will see later, is to learn during the trial and continuously learning in the clinical trial. And the answer to do that is adaptive design, okay, in general, as you will hear this afternoon in many other talks as well. So the goals for biomarker-based adaptive design, again, are in threefolds. First is to identify prognostic and predictive markers for targeted agents. Okay? Prognostic markers are the markers that you can predict the outcome regardless of what treatment you give to the patients. For example, performance status, stage, etc. For the predictive marker, on the other hand, is associated to which treatment. Okay? A marker that can predict the outcome of particular treatment. So that's the first goal, is to identify markers. The second goal is to test the treatment efficacy. And as you also heard this morning from Andy, okay, even in the Bayesian design that we want to control type 1 and type 2 error rate, to have a desirable operating characteristics, we like to maximize the study power to test for effectiveness of the treatments. So in a way, this is called group ethic. Thirdly, we like to provide better treatment to patients enrolled in the trial. We like to assign patients to the better treatment with higher probability based on the up-to-date information. So one goal is to maximize the total number of successes in the trial to maximize the individual ethic. And you can readily tell that the objective, these two objectives, sometimes conflicting with one another or fighting with one another, whether you should put group ethic first or individual ethic first.
You promised we would also learn. You promised we would learn.
Yeah.
But we are only testing.
Oh, I see. Well, this testament is not statistical sense. Okay, it's not statistical hypothesis testing, sorry. It's not precise enough. Okay, we like...
Yeah, he got type 1 and 2.
okay, yeah. Okay.
There's a reason why I'm asking, because like many talks we hear, they go after the optimal design,
Right.
which I understand as being
Yeah.
very targeted upon learning about the parameters.
Right. I will argue estimation is more important than testing.
Thank goodness.
Okay, so what's about this BATTLE trial? BATTLE stands for Biomarker-based Approaches for Targeted Therapy for Lung Cancer Elimination. So the
Got
setting,
lucky to have got such a nice acronym.
yeah, you know what? This trial was funded by Department of Defense, so it's very And you know what? Also, it takes many battles to win the war. Right? So we, as you can see later, we also this trial is done, but we have battle 2, battle 3, coming up.
Battle continue.
Battle continue, yes. And like I spy 2, I spy 3. Okay, so the patient population is stage 4 recurrent non-small cell lung cancer. Primary endpoint is 8 weeks disease control rate. Okay, so it's a very short binary endpoint. We have 4 targeted treatment and 11 biomarkers pre-identified. We have only 200 evaluable patients to achieve these 3 goals that, as I mentioned earlier. So the design was published 2008, and the whole trial result was recently published in Cancer Discovery. So how do we do that? Yes.
What do you mean by a biomarker effect?
Yeah. Test the biomarker effect means that
What is biomarker effect?
it's a biomarker predictive or prognostic.
So means that, okay.
Yeah. Is the
It's
biomarker
not
useful?
Biomarker changes, it's that the clinical endpoint changes due to
Right, okay.
treatment.
Yeah, I'm sorry. I didn't make it clear. We are not that interested in change of biomarker. We are interested in if biomarker correlated with outcome in a prognostic or predictive way. Okay, so just quickly, show you that what are these markers. So we have several markers on the EGFR pathway, like mutation, gene copy number, polysomy, amplification. And we also have markers like KRAS, BRAF mutation. We have marker on the angiogenesis, VEGF, and VEGFR2. We have RXR and cyclin D1 markers. And patient could have, all negative result on all these markers, right? And we also have some patients that we don't have enough tissue to do the marker analysis. So we group them into group 5. So the way to kind of reduce the number of markers is by grouping them. And the summary of the design is that we have 4 treatments and we have 5 biomarker groups. Okay, so you can say that we can have these 4x5 tables. We can look at the effect of individual markers. Okay, and the way we also did it is that we assign patients into different markers based on a hierarchical system. Means that if they are EGFR positive, they are in this group already. Otherwise, if they are KRAS, BRAF positive, then they're in the second group. Okay, so you can evaluate the marker effect and treatment effect. For the design, we have equal randomization initially and followed by adaptive randomization. And our target is to get 250 patients enrolled. Okay. So the schema is like this. When patients are eligible and enter into the trial, they enter into this so-called umbrella trial, and we stick a needle into the lung, or other metastatic sites to get tissue, to get this thing called cold biopsy. And we analyze all the markers. We group the patient into these 5 groups, and we randomize them, into one of the 4 treatments. And the primary endpoint is 8 weeks disease control.
Jack, I got
Yes.
a question. It seems like with 250 patients where you've got that many treatments and that many groups that you're likely to not have patients in some of those groups.
We have 1 cell we couldn't fill. Yes.
Also means you're spreading yourself awfully thin, no?
Yeah, that's right. So again, this is a phase 2 trial. It's not a phase 3 definitive or confirmative trial. This is more like a learning. Yes.
So when you categorize the patients into marker groups, is there a specific ordering you are considering?
Yes. As I said just briefly.
EGFR
First.
and
Yeah, that's right.
So the order might matter, right?
Correct. Oh, sorry. So the underneath is the base model is a Bayesian hierarchical profit model. So we have this continuous latent variable and then group them to make them the binary variable and its appropriate model. And you can see more details about this. Actually, this is a very simple hierarchical model.
J is what?
Okay, so this I subject, J treatment, and K marker.
So you're borrowing strength across markers for the same treatment, for example.
Correct. Very good. And this sigma squared decided how much borrowing we have. Okay.
So what is the model? That was just for notation. What is the model?
A model is a logistic model. I mean, Fourier model, sorry.
What's on the right-hand side of your logistic model?
This,
What's on the right-hand side of your logistic model?
oh, I see. Because we already have the treatment and marker, right, groups. Basically, we have only 4 treatment and 5 marker group, even though there are 11 marker, but we put them into the 5 groups. So the group mean is mu JK.
It's fully saturated.
Yeah.
So actually, when we're discussing the model already, didn't you tell us before that there was some monotonicity, like certain treatments are targeting treatments for certain subgroups? That's not in the model, right?
No. There's no model. Okay, the assignment of the patient into the marker group has some hierarchical, way of setting it. But once we construct this 4x5 table, there's no order relationship.
Right. So you're throwing away prior information because.
Yeah, that's right. Okay, so as I told you that initially we will do equal randomization, then we will do the adaptive randomization afterwards. The way we do adaptive randomization is proportional to the marginal posterior disease control rate. Okay, so it's just get the posterior estimates of the disease control rate for that subgroup, and then suppose this patient is in marker group 2, and then you just then to get to assign to treatment 2, treatment 1 will be proportional to what's the disease control rate for this marker group patient get treatment 1 over all the other. If you give it to all the other treatments, the sum of that, then and just use that.
But Jack, I'm confused. Are the biomarker groups mutually exclusive?
Yeah.
They're partition?
Yeah.
They can't overlap?
They can't, because they're hierarchical assignment.
So they can't be positive for more than one biomarker?
Correct. And then we also set the minimum randomization probability to 10% to ensure reasonable probability to put the patient into the arms that for that marker group of patients, they are still available.
I'm sure you probably have thought about it, but presumably when you do adaptive randomization, you end up different the number of patients in different groups.
Correct.
And therefore the variability associated with each
Correct.
summary could be very different.
That's right. That's the advantage using the the probability of P1 greater than P2. Okay. And this one, when we design, and that also, but if you use P1 greater than P2, as been discussed earlier, it's more extreme. So at that time when we designed the trial, actually in 2006 or 2000, we just think that we just do it simple way, just a posterior mean. But important thing is these two. Okay, we have a suspension rule for randomization. If the probability disease control rate greater than 0.5, which is our target, given the data is low, then we do not put patient in that particular, for that patient marker group, we do not put patient into that arm. And at the end of the trial, we declare treatment is effective in a marker group if probability of disease control rate greater than 0.3, which is the norm, is greater than 80%. So it has to be better than the norm with high probability. You declare a success in that subset. But if the chance of effective treatment for that marker group is low, then you don't put patient there.
Have you said how you put the prior variances on the priors on the random effects variances? Yeah,
the prior is a very vague prior. Basically, we don't have any informative prior in this trial.
On the variances?
Oh yeah, the variance.
On sigma squared and
Yeah, we calibrate it such that it's toward the vague part, because we actually struggle that quite a bit. We don't want to borrow it too much. We don't want to have it not borrow at all. Yeah, so I think that's it.
Do you use inverse gammas or uniforms or what?
No, because this is
For the variances, for the
yeah,
left
here,
side.
here.
Yeah, what about,
The variances on the taus,
Yeah,
right, the prior on the taus.
right. I think so. Right, I think it's inverse
The
now.
inverse gamma has
Right,
fallen into disrepute lately, so.
right, right. Okay, so
And just to finish
yeah,
this question seriously, and when you see conditioned on data,
right.
do you consider the enrollment information is also considered as a
Yes,
data? So it's
available.
conditioned on enrollment as well?
Yes, all the available information at that time. Some patient may be enrolled, but we don't have outcome yet.
And when you compute all these probabilities, it's already in this Bayesian formulas.
Yeah, that's right.
So distribution of enrollment you also somehow take into account when you do all other
No. Just whatever patient we have. In other words, we just use all the available information at the time. We didn't model the distribution, how fast the patient come in, etc.
Well, what's the time frame for evaluating response
8 weeks, and we average enrolling about also maybe randomized 7 patients a month, something like that.
So
But
you
the
could
total-
have 14 patients before you can evaluate anybody.
Yeah. There's always a lag. Okay. Okay, so maybe I can skip this slide. It's been shown earlier. There are different ways to do the adaptive randomization. Okay, so pictorially it's like this. Okay, so if you have a randomization probability on the y-axis and this number of patients on the x-axis, if you do equal randomization, okay, and this shows you if you have 80 patients and then P1, P2 are 0.1 and 0.3, and then on the left panel shows the randomization probability for treatment 1, on the right shows probability for treatment 2. As you can see that is a mirror image. Basically they converge to 0.5. If you do adaptive randomization using this P1 hat over P1 hat plus P2 hat, then the probability randomized into inferior arm decrease over time, and then on the contrary, probability randomized to the better arm increase over time. And in the battle trial, okay, we also evaluate, this is just an example how adaptive randomization works. So this is a simulated example. So you will see a short movie, okay. On the left panel, you will see number of patients put into one of the 4 arms. And on the right, it shows the randomization probability change over time. So we start with equal randomization with 10 patients in each arm, okay. So as you can see here, so when you grow to 40 patients, then we see 10 patients randomized into each arm, and the randomization probability hasn't changed. But then after after that, then the randomization probability will change, okay? And I should tell you that in this one that we have the disease control rate for the last treatment is 0.8, is the best, and then the second one is the worst, it's 0.05. So that's why after 40 patients, the last treatment get more and more patients over time, and then the second treatment has the least number of patients enrolled, and this will go up to 160 patients, then stop. So this is how it plays out.
Did you fix the randomization at 5%?
No.
It looked like it's at 5% for that one the whole time.
No.
Didn't have a minimum.
What happened
No.
to the biomarkers in this design?
No, this is one particular biomarker. This is an example. This is not the real. I will show you. Will see the other one. Okay. So I guess I'm going to run quickly this part. I think Andy mentioned this Horn and Franklin's the papers. Okay, they claim from their point of view that it's not worthwhile, and it's not worthwhile to do the adaptive randomization, because if you look at number of non-responders, it could be bigger than the equal randomization. But Don's commentary says that he agreed with their calculation but not their conclusions, because greatest potential adaptive randomization is multi-arm trials, okay, and adaptive design still can be very appealing from other point of view. Yeah. But numerically, this is what happened. This is taken from Cohn and Flagran's paper, and we simulated. So basically, we had a control group and experimental group, and here shows the response rate, and we can do the one-to-one randomization. Then you need 132 patients, okay, and or 1-to-2 randomization, you need 153 patients, or adaptive randomization, you need to have 140 patients, okay? If you look at this number highlighted in the red box, you can see that indeed adaptive randomization has more non-responders. This shows the number of non-responders than equal randomization. Why? It's because it treats more patients, right? If you have more patients, you have more responders and you have more non-responders. Okay. And the number was chosen such that it has the same power, okay, to test the alternative hypothesis of P1, P2 equal to 0.1, 0.2, and 0.4. But if you make them the same, okay, if you force them that the trial has to have 140 patients, means that for one-to-one randomization, for the remaining 8, you give them whatever better treatment at the end of 130. As you can see that, and if you look at the percent of responders, adaptive randomization always wins. And this is true that if you expand it to 153 patients, okay? So in other words, it depends on which way you look at. You know, the frequentist typical thinking is that you like to maximize the power, okay? And you like to have the result out as soon as possible. But then, you know, adaptive randomization, outcome-based is that you like to treat patients more effective in the trial, so it results into imbalance, and your power will be lost a little bit. So if you put them, the total sample size is the same, then actually, you know, adaptive randomization wins. But if you say that how many, you know, if you like to declare the trial success, if under the alternative hypothesis, which design will help you to reach that conclusion earlier, then equal randomization design, you know, will do that. And if you do the 3-arm trial, okay, and we do the same thing, if we do one-to-one randomization, you only need 171 patients. If you do adaptive randomization, then you need 183 patients. So, but if you force them such that trial, okay, all, you know, need to reach 183 patients, then adaptive randomization always beat equal randomization. Okay. And this is the slide. Okay, what I show you is that this is the probability allocated to the experimental arm over the number of patient accrual. Okay. So for the equal randomization, you know, here you put everybody into the with equal randomization, so with 50% probability to the experimental arm. After that, then there are more trial. You put them into the better arm, then the worse arm. Okay, if you have 80% power, then you have 80% chance to put them into the better arm, and 20% chance to put the worse arm. And for adaptive randomization, this gray shade line shows the realization for 10 trials, and then this red line shows the mean. Okay, so it gradually increases until you reach that. So the trade-off is whether you do equal randomization at the end, you give more patients to the better arm, or you like to kind of gradually increase that. We also do the same comparison, but now allow early stopping. Right? And then these two curves shows the adaptive randomization, the solid line, and equal randomization, the dashed line. So if you have early stopping in the equal randomization, then the performance is more like adaptive randomization. So go back to the battle trial, and I'm going to run very quickly, due to the time constraint. So with this simulation to study operating characteristics, so suppose the disease control rate for treatment, for marker group 1, treatment 1 is 0.8, 0.3, 0.3, etc. Means that treatment 1 is the best for marker group 1, treatment 2 is best for marker group 2, etc. Okay. Then we had more expected number of patients put into the effective treatment, as shown in the circles, red circles, and then the probability of declaring effective treatment is high, probability of suspending that treatment marker combination is low, okay? And had we do the conventional design using the Simon's two-stage design and treat each group separately, then we need 400 patients. And this is just to show you that in order to run that trial, we need to have an infrastructure set up. Okay? So we build a web-based applications to register patients, to kind of log in the biomarker information. And we have this is all in the database, and in the database that we call an R code to do the adaptive randomization. Okay, and this is just a screenshot to show you how to register patient, how to analyze marker into the biomarker group by the pathology lab. And then after you have all the information, then basically the research nurse just click a button to randomize patient, okay? And this shows you the chronology of this trial. So we registered 341 patients, randomized 255, and had 244 evaluable patients. And the dotted line are the expected accrual and or randomization, and solid line shows the actual. So actual actually beats expected. Okay, so I'm going to skip this, and this is the kind of the console diagram. And this one shows the randomization probability on the z-axis, and then marker group here, and the treatment. Okay, so this is the actual what happens in the trial. So as you can see, in marker group 2, we have clear winner. For the other marker group, we don't. Okay.
So it almost seems as if the clear winner, the red one,
yeah,
inappropriately pulls up all the other red ones too. Due to your model, because your model was plotting strength across.
Right. It's not. It's actually this is the actual result. Okay. So that's beta arm is sorafenib. So here this number shows the percent of disease control. So indeed, you know, even this is without borrowing. This is the kind of MLE. So it's doing more or less better than the other one, but particularly in treatment group 2. Okay. So this is the overall disease control rate was 46%, and then you can look at the effect by marker or by treatment, and this is the posterior probability of disease control, showing that the lighter one is the without borrowing, and then the
sorry, but
solid one
the posterior distribution
of disease control rate. This disease control rate went from 0 to 1.
Disease control is an indicator for
8 weeks disease control, whether the patient had reached disease control at 8 weeks or not.
Is that
So
like
that's-
stable disease or better?
Yeah, yeah. Correct.
So what are the two lines?
I'm sorry?
What are the two
Or one
lines?
is without borrowing, one is with borrowing.
The different priors, basically.
Yeah. One is like the, yeah.
What do the priors look like? Is the data informing here?
The only very little borrowing, as you can see here.
What do the blue and purple curves mean? What are they?
The purple are the one that just look at the data by itself,
What?
without borrowing.
so just the likelihood.
Right, just the likelihood. Okay.
Oh,
Right. So, okay, and then let me just go to the end. I know my time is coming up. Anyway, if you'd like to know more about this trial result, that please go to the paper. Okay. So the last few slides. So basically, we learned that the biomarker-based adaptive design is doable. It's well received by clinician patients, and also prospective collection of biomarker samples to do biomarker analysis is provide wealth of information, and you can treat patient effectively and pre-select. Marker is not a good idea. What we learned is that, you know, actually those 11 marker we pre-select is not the best, and also bundling marker into marker group is not good. Okay, and you need to watch for the time drift and try to avoid it, which I don't have time to talk about. We also learned that adaptive randomization should kick in earlier. Okay, this is the one. If it is the take-home message, okay, for this kind of outcome-based adaptive biomarker-based adaptive trial, you know, adaptive randomization only work well when we have good drug and good predictive markers. Imagine that if you don't, then you basically fall back to equal randomization. But you know, it will learn along the trial and do the right things. And in this trial, it's basically the discovery platform, so it needs to be confirmed in the future. And this shows you the design that we are doing now. So right now we have this battle 2, basically it's a 2-stage design. In the first stage, we only use KRAS mutation to randomize patient, but we try to develop signature and use it in the second stage. So I guess that's as much time as I have now. Thank you.
Thank you. Any comments?
Adaptive randomization is actually lots of things. So which one did you use?
The outcome-based, right, based on the disease control rate.
No, I mean, what was the criterion for AR? Was it just probability, you know?
Yeah.
I mean, what was it?
Proportional to the posterior mean of the estimate. Yeah. Yeah.
Have you tried, at the end of the battle, have you tried analysis where you ignore the biomarker groups? Because one drug is definitely better in all groups, right? Have
so
you not
divided
them into biomarker groups? Would you lose much? If you just say, like, you do adaptive randomization on all patients, ignoring their biomarkers.
You said that if we conduct the trial different way.
Just ignoring the biomarkers, but adaptive randomization is the same, and you probably wouldn't lose much for this.
In this trial, probably not. Actually, one of the big failure for this trial, I would say, is that, you know, initially we had thought EGFR mutation is the best predictive marker. That's why we put them into the marker group 1. But then we combine the mutation with the copy numbers and then polysomy, okay, the overexpression based on the immunohistochemistry, and that doesn't work. So actually it dilutes the information. So
what do you mean by the best biomarker? Does it mean that the treatment effect is biggest?
No. Based on the knowledge we have, that's the strongest we have. But then, see, we bundle the mutation with immunohistochemistry staining, and one works, one doesn't. So, yeah. But again, the challenge is this: we have tons of thousands. You know, as Don said, that if you could have thousands and thousands of markers, and how do we know which one works, right? I mean, if you don't do something, if you just try to, you know, use everyone, you have a high false positive rate. So you need to beat that down.
The thing that kind of troubles me is that you have this lag of what is it?
Yeah.
8. And so the simulations may not reflect what's actually going on, because it seems like they're assuming that you have outcome right away. Is that right or wrong? Or
yeah, in the...
Because the lag, we wrote a paper on that 12 years ago. So the lag can kill you, and then you don't really know, you know.
Right.
You've always got this overflow of 2 months of patients. I mean, there's no way out of that, but what's really happening is one number.
Do you use lag in the simulation, I think is the question?
Oh, yeah. I think initial simulation we didn't use it, but later on we did try to look at that effect. It's not much.
It doesn't affect you?
No, it's not much. It's only 8 weeks. 8 weeks.
Yeah. You're only talking 14 patients that are pending, and even if you ignore
14.
it completely, if you add, typically what you'll see is that makes the trial longer. You can get the same thing.
Or maybe a non-MD Anderson question, Jeremy.
So one slide you flashed through, you said you learned something about don't group biomarkers or
Yeah.
Group biomarkers?
Don't. That's why I said that, you know, group one is EGFR pathway. So we have mutation, we have FISH, we have IHC, 3 things. Okay? And we bundle them. It's any one of these positive, we say that is sensitive. But in fact, at the end, mutation works. And the FISH works moderately, and IHC doesn't work at all.
Okay.
So if you bundle them, it dilutes the
That's
information.
an assay issue, right? That's not really a statistical issue.
It is a statistical issue in the sense that...
No, it is a statistical issue because it's a subsetting issue.
Right.
Yeah, and what Jack just said is controversial.
Doesn't turn on.
For example, I don't believe
There's lots of ways to do that. You've got the 3 bits of data,
Yeah, but
information, how to group them
So
together.
Jeremy, it's the usual thing when you look at the data at the end, there's something, oh my goodness, it was great in the KRAS mutant.
So
That's
I
not a
didn't do
general
anything.
conclusion.
I
That's
think
specific to
it's
this
automatic.
No, but
That's
certainly
science, right?
the investigators focused on that, and it wasn't, they didn't
Yeah,
look
so
at
where's
it
the power?
perspective.
Okay.
I think that would be the power, but it's not coming.